I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm really happy to be joined by a wonderful colleague, Professor Arai from Japan, immediate past president of the JATS. As I said, you've put on a wonderful meeting in Tokyo just recently. This is a fun meeting. It's great to have you here.
It's my great pleasure to
Thank
be here.
You and I were talking about the issue of mitral valve repair versus replacement in secondary mitral regurgitation. You had some interesting thoughts. Tell me about that.
Right. In case of the severe mitral regurgitation, they recommended valve replacement rather than repair. But when you look at the real precise data of the repair without recurrent mitral regurgitation, that they have a much better reverse remodeling. So what that means? So I think one thing important is patient selection.
Correct.
And I think another thing is the selection of the repair technique.
Okay.
So they say it's a repair, but most of the patients only downsized annuloplasty.
Okay.
What that means? Downsized annuloplasty have two problems. One is tethering of the posterior leaflet.
Okay.
It is a cause of the recurrence of the mitral regurgitation. And another thing is functional mitral stenosis. So it's two big issues.
Interesting.
Yeah. So the problem is that tethering and the ventricular disease. So not only the ring, but we have to do something for the subvalvular procedure, second cord cutting, or papillary muscle approximation, or papillary muscle relocation. So these kind of things, we have to tailor the procedure for each patient. Not solution is not good. So we have to tailor.
That's interesting. And that's your approach now in Japan when you're doing these patients?
Yeah, we are very interested in the various kind of repair. Somebody doing approximation,
right.
And I prefer the bilateral relocation, papillary muscle relocation.
Okay.
And sometimes I put a patch augmentation for the posterior mitral leaflet.
Cool.
And somebody does just only the posterior mitral leaflet augmentation. So either way, we could get much better results than just a replacement.
And selection of patients, obviously if you have a inferior or posterior aneurysm or a dyskinetic area, those patients still, valve replacement might be superior or not?
Yeah. In Japan, we still have a ventricular reshaping procedure.
Okay.
So if we have a problem of the ventricle, especially for the posterior ventricular aneurysm,
right.
we repair it. And then it's an essential method to repair this kind of problems.
Cool. That's great. Where do you see the transcatheter therapies for mitral valve regurgitation generally?
You mean a mitral creep?
In Japan. So
Yeah.
there's been a lot of interest in COAP and all those, but what about in Japan?
Recently, we just started mitral creep. So the cardiologists are excited about it.
Right.
So they're excited about it. And recently, the COAPT data shows a real nice result. But they just comparing to the maximum medical treatment.
Right.
It's not comparing to the surgeries.
Right.
And they still have 29% of the mortality at 2 years, even if they're using that. But the CTS trial shows the mitral valve repair group still only 90% of the mortality at 2 years. So I'm sure we have much better result. And for the personal experience of mine, 2 years mortality is only 13% of this kind of patient.
Interesting.
So I believe repair have much power than just clipping.
Good. That's great. Listen, Professor Arai, you have been a wonderful friend to many of us in cardiology and cardiac surgery, and we're always thrilled to see you, and thank you for all your contributions.
Thank you. Yeah, actually, sometimes cardiologist are a good friend of mine, but sometimes a competitor.
But you've always been a good friend of ours, so thank you. Thanks
Thank you
very
very
much,
much.
and thank you for joining us.